If your baby was born early, you've spent a lot of time in the NICU, you've probably become an expert in a lot of things you didn't think you were going to be an expert on. And then we add on top of it an eye exam, which feels like it's also really traumatizing. ROP is retinopathy of prematurity. And basically what that is when there are abnormal blood vessels that grow because your baby is premature. Typically, the blood vessels in the retina, which is the camera film of the eye, they don't actually fully mature until a baby is about 38 to 40 weeks gestational age. The blood vessels that can grow after birth in premature babies sometimes are a little bit fragile. When you have a baby in the NICU, your world turns upside down. You were likely pregnant. You were thinking you were going to have a baby delivered at 38 or 40 weeks, and then all of a sudden, you're in the hospital 3 or sometimes even 4 months early, dealing with so many doctor's visits, tubes, and maybe you can't even hold your baby yet, except for just a few minutes. There's IVs running everywhere. And then the nurse says, oh, it's time for the ophthalmologist to come in and see you. And you don't understand, why does your tiny baby need to see an eye doctor? Let me tell you about one of the first times I got called in. The nurse called me in to see a baby for retinopathy of prematurity. And the baby was 26 weeks old and was on oxygen. And we tend to do these rounds really early in the morning, usually 7 or 7:30 in the morning, because we have to put the dilating drops in. And I walk in and usually the rooms are dark. And sometimes these poor parents, you guys are staying in these rooms, you're sleeping there in these really uncomfortable chairs. And oftentimes I'm waking you up as I come in. And the parents were super confused. Why does an eye doctor need to see my baby? Or they're not checking the vision? What's going on? And that's honestly such a common feeling. Most parents have not even heard of retinopathy of prematurity. They're really thinking about all of the other aspects of having a premature kid, right? So dealing with the eyes is just one more thing, and something that a lot of parents don't think about. So that's what today's episode is all about. I'm Dr. Rupa Wong. I'm a board-certified pediatric ophthalmologist. And today we're going to be talking all about what is the eye exam that premature babies need, what is retinopathy of prematurity, how can you be your baby's best advocate for the screening exams that we do, as well as for treatment if your baby needs it. Let's just break it all down. So if your baby was born early, you've spent a lot of time in the NICU, you've probably become an expert in a lot of things you didn't think you were going to be an expert on. Their oxygen status, their feedings, whether or not their blood was drawn, all of these different things. And it's traumatic. And then we add on top of it an eye exam, which feels like it's also really traumatizing. But I want to tell you why this is really important and why most of the time you don't necessarily need to worry about the eye exam itself. It's not going to harm the baby. The bright lights, just going to go into everything, because a lot of times when the ophthalmologist, the pediatric ophthalmologist, is doing the rounds, they might not have time, unfortunately, to really discuss every single aspect of the screening and of the treatment with you. You might have been handed a piece of paper and told, here, this is what retinopathy of prematurity is. So I want to just make this a little less scary for everyone and talk about what you're looking for. So ROP is retinopathy of prematurity. And basically what that is retinopathy is when there are abnormal blood vessels that grow because your baby is premature. Typically, the blood vessels in the retina, which is the camera film of the eye, they don't actually fully mature until a baby is about 38 to 40 weeks gestational age. So if you have a baby that was born 24 weeks or 26 weeks or 28 weeks, that retina is not fully mature. And those blood vessels are still growing because they wouldn't have grown for at least another 10 or 14 weeks. Because of that, we have to monitor them. The blood vessels that can grow after birth in premature babies sometimes are a little bit fragile. And they then can break and they can lead to leakage and even possibly a retinal detachment or blindness. Those are absolutely worst case scenarios. That's not something that often happens, but this is what we're screening for. And this is why it's so important to allow the ophthalmologist to come in and do these screening exams, even though they can feel truly scary. So who do I examine in the NICU? Basically any baby that was born before 31 weeks of age. So even if your baby is 30 weeks and 6/7, meaning 30 weeks, 6 out of 7 days, but they don't quite meet that 31-week mark, then I'm doing a screening eye exam for the baby. If your baby is less than 1,500 grams, so we deal with grams in the NICU, not pounds, that's about 3.3 pounds. So if your baby is less than 31 weeks gestational age, 3.3 pounds, or has had like a really chronic course, meaning there's just like a lot of medical problems, there's a lot of bowel things, they've had to have a lot of oxygen. Now, oxygen is good because it keeps your baby alive, but they found in several studies that the higher the oxygen is, unfortunately, it causes more retinopathy of prematurity. So the nurses and the doctors, they're doing their best to titrate that because it's increased survival, and that's been shown in these boost studies and the support clinical trials. But we know that higher oxygen causes worsening of retinopathy of prematurity, and that's because when the baby is in utero, it's actually a low oxygen environment. And that's the way those retinal blood vessels are starting to grow. And then when they are out in the world and they're getting a lot of supplemental oxygen, just to keep your baby alive, that can cause these fragile, abnormal blood vessels, which therefore lead to detachment. So it's this kind of fine titration. You might notice, oh, why is my baby's oxygen not at 100? Because it's one of those computer monitors that you see. You see those O2 level sats. You might want it to be at 100% all of the time. And honestly, that's what nurses used to do 20, 30 years ago until all of this data came out to say we need to actually titrate it. We don't need the baby to be at 100%, even 98 or 97% is good enough, and that'll minimize the risk of retinopathy of prematurity. So even if your baby wasn't born premature, sometimes I'm asked to see babies that were born at 38 weeks gestational age, and they were born at a regular weight, but they had a really complicated course in the NICU. So they want to just check to make sure that we don't see any of the abnormal blood vessels. So even if your baby wasn't tiny, the neonatology team, the big team that comes rounding, will likely call for the pediatric ophthalmologist or sometimes the retina specialist, depending on the hospital. It's either one of us that will come and do these eye exams. So what does the exam look like? You're probably just being woken up by me coming in with my funny little headset. And I usually go in with a nurse coordinator, an ROP nurse, because the nurse needs to hold the baby in a certain way for me to be able to do the examination. And it's just so much safer to have a nurse who's monitoring the oxygen level because babies get a little bit tricky with the eye exam. So what does it look like? Well, first, about an hour before I even come in, the nurses have put in dilating drops into your baby's eyes. These are super safe. They use a very mild dilation drop, but it's going to make the pupils large for about 4 to 8 hours. That's put in about an hour before I come in because it takes about an hour for those drops to take effect. So you'll see the nurses maybe put those eye drops in, and they typically will do 3 sets about 5 minutes apart, depending. Once the baby's eyes are dilated, that's when I come in with my nurse coordinator. And oftentimes, to be honest, I tell parents, you can just step outside. If it was my baby, I definitely would not want to see the exam. Not that I'm doing anything damaging, but the baby is going to cry. The light is bright. It's just one more thing that can feel traumatizing. And the exam really takes about 5 to 7 minutes. And I tell you right away exactly what has happened. So once I come into the NICU room, depending on the type of isolette that your baby's in, my nurse is going to wrap the baby, swaddle them real good so that they can't move. And then I actually will put in a numbing drop into the eye. So that's going to help with any pain. And then I put in a wire speculum. Now, this wire speculum helps hold the eyelid open. And we have to do that because if you've gone in for the eye doctor's appointment, you can hold your own eyes open. Obviously, a baby can't, especially with a really bright light. Then I put my headset on, which is an indirect ophthalmoscope. It's got a bunch of different prisms, and along with the magnifying glass, it allows me to get a really magnified view of the retina. And this is why we had to put the dilating drops in. The dilating drops open up the pupil. So think about it like opening up a window really big to see a better view instead of just looking through a little crack. That's why we need to put the drops in. You can't really see well if the baby's eyes aren't dilated. And I really have to see into the entirety of the retina. So I have to see the periphery of the retina. So again, if you've ever had your eyes dilated and you go into your eye doctor's office, likely they would say, okay, look up and right, look to the right, look down and left. We're trying to get to the periphery of the retina, see everything all around. Obviously, with the baby, you can't tell them where to look. So this is the part that I think a lot of parents have trouble with, and I would too. I'm a mom of 3. I would not want to see this on my own child. We will use a little instrument to move the eye around. Sometimes it's just a Q-tip, like a very skinny Q-tip called a Calgi swab. Sometimes it's a little metal instrument that looks like a spoon called a scleral depressor. And that's how we can move the eyeball around so I can see into the periphery of the retina. Because what I'm trying to judge is where are the retinal blood vessels? Because like I said, at 26 or 28 weeks, the baby's retinal blood vessels have not grown all the way into the periphery. So I need to figure out at what zone are those blood vessels, and then I keep monitoring until we see that vascularization, those blood vessels fully grown out to the very edge of the periphery the way we would for a 40-week-old. Now, unfortunately, because the baby's premature, that means that it's not going to happen right at 40 weeks necessarily, but usually that's where we see full maturity or mature vascularization. So there's different zones. It starts with the centermost aspect of the retina because that's where the retinal blood vessels start. They start from the center and then they grow out and then they grow to zone 1, zone 2, and then zone 3. Zone 3 is the last zone right before maturity. So we're looking at the zone, the location of the blood vessels, and then I'm also looking if I see any retinopathy of prematurity, if I see any abnormal blood vessels. And there's different stagings for that. So there's stage 1 all the way up to stage 5. So stage 1 is when I see a little line. The blood vessels have just kind of stopped growing, but there's nothing super abnormal yet. This is pretty mild retinopathy of prematurity. It is ROP, but it's mild. It's nothing to be worried about. Stage 2 is when there's a little bit of a ridge. Okay, we're getting, the blood vessels have grown. There's a little bit of abnormality. It's something that we're going to continue to watch. It's not no ROP. It's not stage 1, so it's a little bit more concerning, but typically not anything we have to treat. Now, stage 3 is a little bit more concerning. That's when we start to see some bleeding. These blood vessels have started to break and caused blood in the retina. And that's when we start to you might notice, all right, now the eye doctors are coming a little bit more frequently, especially depending on what zone it is. Stage 4 is a partial retinal detachment. Hopefully, your baby is never going to get to that stage because we usually intervene at stage 3 level. And stage 5 is a total retinal detachment. And if it comes to that, this is very hard to treat. This is what can lead to blindness. And this is why we do these eye exams so frequently, so we can continue to monitor, because it can go from stage 0, which is no retinopathy of prematurity, just immature blood vessels, to stage 3 or stage 4 within a month. So a lot of times we are monitoring very frequently, especially if your baby's really preemie, if your baby had a lot of oxygen, or if they were really small. When do we treat? There were a couple studies, one called ET-ROP, one called cryo-ROP. I'm not going to bore you with the details, but these studies really showed us as ophthalmologists when is the best time to treat. When will this ROP, this retinopathy of prematurity, just go away on its own? Because sometimes it absolutely can. So they kind of looked at all of these babies and they looked then at which stages progressed to that terrible blindness from retinal detachments and which ones didn't. Because we only want to treat the babies that really need it. Treatment's not completely benign. There are risks and side effects associated with it. And if it's going to go away on its own, then we're not going to treat. So as I mentioned, stage 1 ROP, we generally do not treat that. Usually that's just going to get just resolve on its own. Even we might just watch it every 2 weeks. That's typically the standard screening, is every 2 weeks we'll come in until we see mature vascularization. Most of the time, the blood vessels become mature. I say, see you later in my office in 6 months, and I really never have to worry the parents about any of these discussions. Stage 2 as well is going to be something that typically resolves, and that's what they found in these studies. Now, what they found is if there's really severe disease in that zone 1, that central area, that has a higher percentage of progressing towards a retinal detachment. So those are the things that we need to treat. Those are the cases that we have to act to prevent blindness. This is called type 1 ROP. We used to call it plus disease. And sometimes even in zone 2, if it is a very advanced stage 3, and there's many different types of criteria for that. But even in zone 2, we might need to treat. So it really does depend upon the zone and the stage and just how abnormal the blood vessels are if the ophthalmologist is going to recommend treatment. So what they found in these studies is if these babies with really advanced disease in zone 1 or in zone 2, kind of moderate disease as well, if they're not treated, then 45% of them end up losing vision. But early treatment can cut that risk in half. So that's really huge. And that's where we make these decisions about recommending treatment. So what does treatment involve? So there's 2 different types of treatment. The older treatment is laser treatment, which is still what we do in the hospital where I see babies at. And it's tried and true. What we're using kind of an instrument, almost like what we use to examine the baby. It's a headset, but it's connected to a laser. And we apply laser into the periphery of the retina where there's no blood vessels, but there's a lot of bleeding. And what that does is it cuts down the oxygen to that retinal periphery. Usually we've got to do this in the operating room under anesthesia. When I trained in Boston Children's 20 years ago, we actually just did it in the NICU. So it depends. It might be in the NICU or it might be in the operating room, depending upon where your baby is at. And it's a really effective way of stopping the abnormal blood vessel growth. But in about the last 10 to 15 years, there's been a newer treatment called anti-VEGF treatments. So these treatments, it's actually a chemotherapy agent, and it stops the blood vessel growth, right? That's what we're trying to do with retinopathy of prematurity, is stop these abnormal blood vessels from growing. So it stops the blood vessel growth. It's an injection that they inject directly into the baby's eye. This is also what's used for macular degeneration for older adults. So a lot of retina specialists were using this. There was concern initially about how injecting something might affect the brain for especially these premature babies, but it's found to be relatively safe, but it's something to consider. And the nice thing about the VEGF injections, the anti-VEGF injections, they can be done right at the bedside. So right in the NICU, and it's really short. So when I do a laser, it takes about 2.5 to 3 hours. When you do an injection, it's 5 minutes. You put a drop of numbing, you put some antibiotic, you do some betadine, and then you just give the injection and you're done. So why would anybody want laser over anti-VEGF? Because it seems like it's so much faster, it's so much easier. Well, one concern is, like I said, the blood-brain barrier, because this is a medicine that's being injected into the eye. So that sometimes for certain babies, we might not want to do that, just depending on their clinical course. Laser has a really long track record. It's been the gold standard for a really long time, and we know that it's effective. And it seems to quiet the ROP down a little bit faster. The course is a little bit longer. The follow-ups are longer with the anti-VEGF treatments. So we typically have to wait longer for the abnormal blood vessels to become normal and then to grow. Because even if we stop the abnormal ROP, I still want to see mature blood vessels growing all the way to the periphery before I'm going to say, see you later. I don't need to see you for 6 months until you come and see me in the office. So that's part of it as well. But the cons of laser is that it destroys the peripheral retina. So for some people, it can give a defect of their visual field when they're older. Your baby's not going to notice, your child's not going to notice, but it is there. And I have seen kids who had laser as 25-year-olds, and when we do a formal visual field testing, they do have a little loss of their visual field, and that's normal. That's to be expected when you have laser, because we're quite literally destroying the retinal tissue there. And so laser is not really ideal if there's a lot of central disease, because we'd have to laser so much of the retina that it would cause a problem. So if there's really advanced progressive central disease, then likely your ophthalmologist is going to recommend the anti-VEGF treatments. Now, ROP can still come back later, even if you have treatment. That's why we still have to continue to monitor, because it can regress, which would be great, could go away, but it can also come back. And sometimes then a second laser treatment is needed or a second injection is needed. So just because you've had one treatment doesn't mean that you're out of the woods totally. And this is really just not a one size fits all decision. The clinical course is so different for every single baby that it's going to be a discussion that you have with your ophthalmologist. I'm going to give you some questions that you can talk with your neonatologist and your ophthalmologist about. So trying to decide between the two, they're likely going to make a recommendation, and they're going to make a recommendation based on weighing all these factors in. But I always think it's great for parents to be involved in the decision making and to understand the decision. So now you know what ROP is, you know when we treat and the different types of treatments. Let's get to the questions you should be asking your doctor, just so that you feel a little bit more confident and a little less nervous about what's going on. So if your baby's still in the NICU, a really good question is just, will my baby need an eye exam while they're here? Not every single baby needs the eye exam in the NICU. Sometimes if your baby was born at 30 weeks, they might go home before they even have the eye exam. And the timing of that first eye exam depends on when they were born. And so typically we do the first exam anywhere from about 3 to 4 weeks after birth. So for a 24-week-old baby, they're likely still going to be in the NICU at 28 weeks, but a 30-week baby might be home by 34 weeks. So it's not always going to be in the NICU that you have the eye exam. You can also ask them who will be doing the eye exam. Typically, it's a pediatric ophthalmologist or a retina specialist, but find out. One is not better than the other. Both are extremely well trained to be able to do this. And then once your baby has had an eye exam, ask what stage of ROP does my baby have. If they say stage 0 or immature, that means absolutely nothing abnormal. We're just waiting for the baby's retinas to catch up, to mature. But if it's stage 1 or stage 2, not super concerning. Stage 3, 4, or 5, hopefully you're never going to hear stage 4 or 5. That's going to be of a little more concern. How often will follow-up exams happen? Usually, if there's nothing too worrisome, I see babies every 2 weeks. If things are starting to pick up and I'm a little more concerned, I want to measure more frequently. I'll see them every week. And even sometimes I've come in and seen babies every 3 or 4 days. If I'm really worried, is this baby going to need treatment? And if your baby needs treatment, ask your doctor about the options. Laser versus anti-VEGF, why they recommend one over another. They should absolutely have that discussion with you. If not them, then really there's going to be an ROP nurse coordinator. There almost is in every single hospital that I've worked at. And it's honestly just such an important part of the process. And usually that ROP nurse coordinator, that is all they do, is they are there to help guide you through the ROP process. They don't do anything else. They don't see anybody else. They're not taking care of babies on the floor. That is their job, is to have these discussions with you and answer all of your questions. So you might not necessarily get the answers from the ophthalmologist, but you will 100% at least have a discussion with the ophthalmologist, and then you can really dive deep with your ROP nurse coordinator. And then as you prepare to go home, you can ask, will my baby need another eye exam once they're home? More often than not, yes. And so I will also see babies for follow-up because they still haven't matured. Their blood vessels still haven't matured, so we're still seeing them at 38, 40, sometimes all the way up to 50 weeks gestational age. So I see them as an outpatient. It's really pretty much the exact same process with the dilation drops, the swaddling, the lid speculum. It's all the exact same, but we're just doing it as an outpatient instead of in the NICU. Will this affect my baby's vision long-term? And if we don't do treatment and your baby needs treatment, 100% it will. If they had ROP and it resolved on its own, then usually it does not. And this is why just keeping those follow-up appointments, even though I know there's so many, you've got to see the dietitian and the nutritionist and the pediatrician and the neo. I mean, there's so many follow-up appointments, even when you get home. Honestly, I know that it's easier when you're in the NICU, everybody comes to you, and then instead of you having to bring your little baby, sometimes on oxygen, to all these multiple appointments. But the eye exam is really important because things can go south very quickly. And if the ROP gets worse and we don't see it and we aren't able to treat immediately, this is one of the true emergencies. We want to treat within 72 hours of seeing retinopathy of prematurity. So I've gone in and treated till midnight because that was when I could get the operating room time. And that's when, just to get in that window of being able to treat. So really important to maintain those follow-ups. And then the last, should I watch for any signs of vision problems at home? And this is where, especially if your baby's preemie, you're not really going to notice things visually because they're still developing their vision, but your doctor is going to let you know if something more needs to be done. Just remember, there's absolutely no silly questions. I always want to hear from parents and be able to address their concerns. So hopefully your doctor and the team taking care of you feels the exact same way. I hope this episode's been helpful and gives you a little less to worry about. At least you know what to expect and to prepare for the eye exam. It's not damaging to your baby's eyes. That bright light, I know, can seem really scary, but I promise you it does not hurt the baby's eyes. And it's uncomfortable, but it is not super painful. And we do everything we can to make your baby comfortable while we're doing the eye exam. So that's it for today's episode. Thanks for joining us today for In Focus. I'm Dr. Rupa Wong. Until next time, see you soon. Thanks for joining me on In Focus. If you found today's episode helpful, I'd love for you to share it with a friend, leave a review, or hit that subscribe button so you never miss an episode. For more tips on eye health, parenting, and staying focused in a busy world, follow me on Instagram at Dr. Rupa Wong or head to drrupawong.com. Until next time, keep your vision clear, your priorities focused, and your family thriving.